Hello, and welcome to the Race, Wealth, and Health Podcast, a podcast that serves to educate and empower while we explore the intersections of social justice, economic empowerment, and holistic well-being within communities of color. I am your host, Dr. Joycelyn Morris, and I invite you to join me as we dive deep into the crucial topics that shape our lives, challenge the status quo, and strive for a more equitable future for all. Hello, welcome everybody to the Race, Wealth, and Health Podcast. So excited to have on the podcast today, Dr. Brittany Lane. Hi, Dr. Lane.
Hi, how are you?
Good. So good to have you. Just a brief introduction. Dr. Lane is a public health research scientist. She currently serves as a senior epidemiologist for an American Indian tribe in Arizona. She received her master's in public health and international health and development, as well as her PhD in global community health and behavioral sciences from Tulane University's School of Public Health and Tropical Medicine. Dr. Lane's expertise is in community-engaged research to address racial and ethnic health disparities. And I'll leave it at that because I don't want to take away too much from your own introduction and path into this work. But again, welcome, Dr. Lane. I'm so excited to have you on the podcast.
Thank you for having me. I'm excited to be here.
Awesome. So I like to do a brief introduction of how I met Dr. Lane. So this is going to be a fun one because Dr. Lane, also known as Brittany, and I have known each other for... I should have done the math before we came to the podcast. So probably it is
more than 20 years.
Like 25 plus years. We met in middle school. And so we went to middle school together. We went to high school together. Dr. Lane is also a twin. So both she, myself, and her twin all went to middle school and high school together. And so we became best friends in high school, but we've known each other since middle school. So that's 1996, do the math, which has been a very, very long time. And I think, so I actually became truly friends with her twin first, because her twin and I took French together. And that was the experience, which I will not go into. But we were part of, fun story, we were both part of the law magnet program at our high school. All three of us, only one of the three of us went into law. I just want to note that for our listeners. It's always okay to pivot. And a couple of us have had, like myself, have had a couple of different careers since then. And so as a result of that, we took a lot of classes together and became really close friends. Most importantly, Dr. Lane was very helpful throughout my dissertation process as she had completed her doctorate and just kind of helping guide me. So I am excited to have my dear friend and sister, Dr. Lane, on the podcast. I don't want to assume that people know you as well as I do, obviously. Dr. Lane is here to discuss some of the health concerns and disparities among Black women. And so that being said, tell me a little bit about your work and how you got into this work.
So like you mentioned, which was hilarious because I totally forgot that I was a part of the law magnet and absolutely did not do anything related to law after finishing high school. I actually started out, I am a public health professional, like Joycelyn mentioned, or Dr. Morris mentioned, a public health research scientist. And my research is focused, or the approach that I use is community engaged research, particularly addressing racial and ethnic disparities amongst Black women. And that is my passion. The way I landed into this field, I originally thought that I would go into medical school. I thought that I would choose the route of a clinician. You know, like many people entering college, you have these, goals, and you think because of just society and the way things happen that you either become a doctor or you become a lawyer. I was no different than many people out there. I decided to choose the pre-medical track, and I ended up actually not liking it. During my second year of college, I figured that this wasn't a good fit for me, though I always had an interest in health. I just knew it wasn't the clinical route. I had volunteered at the health department, volunteered at hospitals, and I really, really fell in love with community engagement, community outreach as it relates to promoting public health, spreading public health messages, talking to the people in the community, assessing people's knowledge, their literacy of health issues. And I really fell in love with that. And I found out, there's something that I can do with that. There is a job, there's a degree path that I could follow that will get me to that career that I was desiring. And so I decided to change from a pre-medical track into health science education. And with that, I developed, of course, my interests. I volunteered specifically with the Minority AIDS program while I was in college and just fell in love with HIV prevention because it affected our people, our community so much. And I knew it was something that I really wanted to do. A story that I haven't shared, I don't think I've shared this with you, Joycelyn, and people ask me, and of course, whenever I write any application or any biography and people ask me, how did I develop my interest in HIV AIDS? I actually had somewhat of a personal experience, and it wasn't myself that had the experience with HIV AIDS or anyone in my family, but it was a situation when I was in college. I went back home and I was actually in church. And one of the ladies, she was on the praise and worship team. Everyone knew her in the church, was very instrumental in leading the worship services at our church. She wanted everyone to stay after. The pastor asked if we could stay after church because we had someone in the congregation that wanted to present something to us or wanted to tell us something. And so we were all waiting. My family, everyone was there. It was a crowded house. And this lady that I had known for about at least 3 years of attending the church, who led the worship, she stood up and disclosed to the entire congregation that she had been diagnosed with AIDS. And to me, that was the first time that I ever actually knew someone that I was close to. And I say relatively close to, she was someone, your church family. I used to see her every single day or every time I was at church. She was very instrumental in leading the worship service and everyone knew her. And she had 2 young kids. Sometimes they would sit next to us. And she just told her story of how she acquired HIV infection through sex with her husband. And she found out that he knew he was infected. He didn't tell her. She ended up developing AIDS, and she just shared her story with us. She shared the struggles that she had. She shared the shame. And the reason why she wanted to do that was so that she could educate the community and prevent other people from experiencing her similar issue. She shared, the health of her kids. They were born negative, which was a blessing, and everybody was happy about that. But I also witnessed in that moment some of the stigma and the discrimination that people experience that are living with HIV. And this was in a church setting. And, I noticed some people walked out of the church. Some people weren't really considerate. They didn't want to hear what she had to say. Some people were looking kind of like fearful. They didn't know how to respond. And in that moment, I knew this is the work that I wanted to do. And that really is what fueled me to seek internship and work with HIV prevention among Black women, especially. And after that, of course, in college, another aspect of my career is, and I don't know if it was explicitly stated in my bio, but I have a strong interest in international health issues. So not only am I focused on Black women in the United States, my passion and my focus in terms of eliminating health disparities also applies to Black women globally. Specifically those in sub-Saharan Africa. And my interest in HIV/AIDS, of course, is relevant there because the HIV/AIDS epidemic is extremely uneven, where Black women and people in Africa are disproportionately affected. Young women, especially young women and girls. And so I did a study abroad in college. And I went to Nigeria and I was actually studying language. It was a Yoruba language on a Fulbright group project abroad in Nigeria. And I fell in love. I fell in love with the culture. I fell in love with the country. But I said, I'm going to combine my love for Africa and also my love for public health and make that my career. And that was the path that I took. And that's where everything started from there.
That's amazing. I do want my listeners to know that that is actually the first time in these 20 plus years that I've known Brittany that I've heard that story. I actually did not know that that was the reason that kind of catapulted you into this career. I do want to kind of double back on that though. I'm curious, what year was this? And I watch old shows and there was a lot of information coming out about, especially in the 90s, where people were talking about HIV and AIDS and how it was affecting Black women specifically. And I remember like watching those episodes now and thinking like it was definitely a big push. Have we evolved when it comes to the shame and the stigma around HIV and AIDS?
No, there has been significant progress. We have increased awareness. We have educated people on the fact that there is treatment for HIV. There is we're using treatment as prevention where we have significantly reduced transmission because of things such as pre-exposure prophylaxis, which is allowing people to take or giving people medication that they can take preemptively to prevent HIV infection. And we've also had major achievements in HIV medication and treatment, which people, if taking it properly and consistently, can reduce their viral load in a way where even if they had, a situation where they may have possibly had unprotected sex and may have felt that they could have exposed their partner to HIV, that they could reduce over 90% transmission if they are taking their medication consistently and in the proper way. So we have made advancements in that. But as it relates to stigma and discrimination, that is the issue that we're still having in terms of reducing and eliminating these health disparities, specifically amongst Black women and Black people in general in our communities, and making it very challenging for the work that we're doing. So yes and no. We have done a great deal of educating, shedding light on awareness, providing information about treatment, other ways to prevent HIV in terms of acquiring HIV infection, but we still have a lot to do as it relates to reducing that stigma and discrimination amongst African Americans.
Thank you for that. That's good to know, because I definitely think it's important to take the more macro approach as we're talking about Black women and the health of Black women. What are some things that, what is the current state of health of Black women, right? I know we talked about disparities. Where do Black women sit and sort of situate in terms of health?
Okay. And when we talk about disparities in health, just to be clear for people who may not have a public health background, when we talk about disparities, we're talking about the difference in health status. So we're seeing differences in health outcomes based on race and based on ethnicity. And so overall, when we talk about health equity, because I know now that's something that's definitely the catchphrase, we have critical race theory. We also have talks about health equity, especially with the pandemic. What health equity is, and it's something that we as public health professionals strive, is we strive to make sure that everyone living, all people in this country, all people in this world are able to achieve their highest level of health, regardless of what group they're in, regardless of their socioeconomic status, that they should have the opportunity to receive their highest or to achieve the highest level of health. So when we see health disparities, especially racial and health disparities, that lets you know that there are health inequities, that there are things that we need to address to make sure that especially people of racial and ethnic groups are achieving their highest level of health. And specifically as Black women, we do have persistent health disparities, that we have made significant progress in improving health overall for Black people, and especially Black women. We still see that there are persistent health disparities as it relates to chronic health conditions. Some of the top leading causes of death: heart disease, we have diabetes. We see higher prevalence of those conditions in Black women. We see higher prevalence of obesity in Black women. We also, of course, like I mentioned, HIV and AIDS. Black women are also disproportionately affected by HIV and AIDS compared to their white counterparts, where I think CDC reported, I believe it was either 2019, it was a report that came out, very recent report, but Black women are 15 more likely to die from HIV infection. And this is in a climate in which I discussed that we have pre-exposure prophylaxis. We also have treatment that's affordable, that's accessible, even for those that do not have or who are publicly insured or are lacking insurance. We have treatment options available for them, but we still are seeing Black women dying at a higher rates for these infections compared to their white counterparts. Of course, everyone is aware, hopefully at this moment, you are aware of the difference in the maternal health outcomes of Black women. That's something that we've been discussing very heavily and a priority for our community, especially as Black women. Black women are 3 to 4 times more likely to die from pregnancy complications than any woman in the United States. And
I want to pause there, right, on the pregnancy complication and sort of add, I don't want to say, I'm trying to find the right word. It's appalling, the rates, right? And I've actually had some experience firsthand with a college classmate of mine that died as a result of a complication. I also know a couple of women that almost died as a result of complications, things that were like totally preventable, and people just didn't listen in the hospital room. And I was just having a conversation over the weekend with an associate of mine that recently had a baby, and I was asking her about her process, and she was like, I tried to tell them that I was going into, like, I wasn't feeling well. Long story short, she ended up having an emergency cesarean. And she was telling them, like, something's not right, and the baby has started to lose oxygen. Thank goodness her doctor was listening to her, because the people in the hospital were not. And unfortunately, one of the things that she shared that was very disappointing for her was that the nurse was actually a person of color, right? And that even they weren't listening to her, but thankfully she had such a good relationship with her doctor. Her doctor at like 3 o'clock in the morning was like, "No, I'm going to come," because they tried to discharge her from the hospital, and she was like, "No, I'm not leaving." And so, and this was just a couple months ago. Like her son is only 2 months old, and so I think it's something that happens at alarming rates, and people don't talk enough about. But if
And
you want to share a little bit more about, though, I just wanted to insert that story because it's like
it's too
something
common.
that, it's much more common than people know.
Yeah, and interestingly about that, I definitely want to talk more about that, because that is a common occurrence for Black women and people of color, sadly, and even amongst our own peers. Even like you said, the nurse that she was, dealing with was a person of color. She may have been a Black woman or a Black man. Again, so the issue with, and the interesting thing also about maternal health as it relates to Black people is that your education and your socioeconomic status has no impact on that. Every woman of every educational level, of any socioeconomic status, experiences the poor health outcomes as it relates to maternal health. And the issue with that is, in how you mentioned, which is interesting, is the person of color was also not really listening to her. And one of the things that we discuss in that situation is the quality of healthcare that we receive, the implicit biases that our healthcare professionals hold, whether unintentionally or knowingly, as it relates to Black people in general. Black women, especially in terms of their knowledge about their health. They may believe that they don't know as much about their health as they think white people might know. They also feel that they may know better. They may know more than what you think you know of what you need, or they may think that you're complaining because they think there's been a history that, Black women can tolerate pain more than other women or white women. And those situations, especially as it relates to the relationship with the healthcare provider, the implicit bias and dismissing, the concerns and the complaints of Black people. That's why we're seeing these high maternal mortality rates. One thing that I want to mention, because you talked about health disparities overall, Black women especially experience excess mortality rates compared to white women in the United States. And that's, or just compared to women in general. And that's evident. CDC reported that the life expectancy at birth for Black women is 7 years lower than the life expectancy for any woman in the United States. And this is not just white women, this is any woman in the United States. And so that is evidence of the health disparities and the work that we still need to do as it relates to addressing poor health outcomes in Black women.
So I want to double click on that. So Black women, you said, are 7 times, or excuse me, the life expectancy of Black women compared to any other woman here in the United States is 7 years less. And to kind of go back to we talked a little bit about the maternal mortality, but what are the leading causes of, death among Black women? And if we could talk a little bit about that and what Black women should know, what our Black women listeners should know about these diseases. What are some of the things that they should be aware of?
The leading causes of death in general are, the leading causes of death among Black women are similar to the overall leading causes of women. And the difference, though, is that there are higher prevalences amongst Black women in terms of these leading causes of death. That makes sense. So Black women are disproportionately affected. You're going to see higher rates of certain diseases and conditions in Black women compared to white women. And these are chronic conditions: heart disease, cancers, stroke, diabetes are some of the leading causes of death in Black women. And the reason that you're going to see excess mortality rates a lot of the times, of course, maternal mortality adds to that, but cancer, deaths due to cancer adds to that. The disproportionate in health outcomes for Black women essentially just shows you why Black women are dying more excessively compared to white women. So for instance, like I mentioned, HIV, Black women are 14 or 15 times more likely to die from HIV infection. And this is with treatment in place. Black women are more likely to die from cancers, even if they're not seeing a higher prevalence in cancer. Specifically, I want to say breast cancer. I think white women have slightly higher prevalence of breast cancer, but Black women are more likely to die from it. And that is because they're being diagnosed later. They're not being screened. Again, they're not going into the healthcare facility to be screened, and that's for a myriad of reasons, which we can discuss later. They're also sometimes not being taken seriously. Maybe concerns that they're having, they're not getting the quality of care. They also don't have access to quality of care that our white counterparts do because of difference in socioeconomic status. So just the higher burden of diseases in Black women will explain the excess mortality. And so that's hopefully what
that definitely makes a lot of sense. So like you mentioned, a lot of the chronic issues, heart disease, etc. I think you started to touch on it, but we've been talking about race, we've been talking about health, but what about healthcare and quality healthcare, which means quality providers, access to good insurance that pays a certain portion of things and covers more, diagnostic type exams, etc. How would you describe where wealth sort of comes in and intersects with your research and with your work?
So just to answer your question shorthand, wealth is a major issue as it relates to health, specifically amongst racial ethnic minorities and Black women. And I want to rewind because I talked about health equity, I talked about health inequities, I also talked about health disparities. So one thing that we also need to be aware of are the social determinants of health. And that's something you're also going to hear being discussed commonly amongst public health professionals when we are talking about health disparities. So social determinants of health are the social conditions that impact health outcomes, specifically conditions in which we live, conditions in which we're born into, conditions in which we work, where we grow, where we age. All of those are going to have an impact on our health. And for instance, an example of social determinants of health include economic security, include health care and access, include education. And if you can see, there's a theme. Education, economic security. We talked about quality of healthcare. We also talked about neighborhood and your built-in environment. That's also social determinant of health. And also your social support system in your community. And the reason why I said wealth is extremely important because when you look at those social determinants of health, look at how wealth affects those things, right? Yep. Wealth affects, of course, your economic security, right? The resources that you have, the assets that you're able to attain. Do you own your home? Do you have a retirement fund? You also have wealth that affects education. The more wealth you have, the more income you most likely will have. You'll have a better education. You'll be able to access better schools. You'll be able to pay for colleges, put your kids in better schools. Yep. Addresses health. Are you insured? Are you not insured? Do you have money to pay for healthcare services? Also, the neighborhood that you live in, your wealth. If you have more wealth, if you have higher income, you live in a better neighborhood. So this is why wealth is woven throughout the issue as it relates to health disparities of Black women, Black people in general. And so any condition, anything that you can bring up in terms of health. We talked about HIV. The only one that's interesting. Remember, we talked about maternal mortality. That one really doesn't have an impact of one's health or wealth or education level. But other conditions, such as the chronic health conditions, when you look at heart disease, you're looking at neighborhoods. You're looking at, is my neighborhood safe? Do I live in a place that's safe? Can I walk? Can I go to the park? You're also looking at pollution. You're looking at water. See, all of these things affect your health. And when you look at the top part, you look at the overarching thing, it's economic, it's your wealth, it's your income that will affect it. Also, what needs to be stated if we're talking about social determinants of health is the wider structural force or the wider system as it relates to structural racism, where we have racism that has been interwoven into our systems for centuries that have impacted the wealth of our communities, which ultimately impact the health of our communities. And so that's what has also made it challenging for our work, is dismantling those systems, these policies that we have in place so that we can improve the health of Black women, of other racial and ethnic minorities, to make sure that we are achieving that health equity, that we're making sure that we're giving them the things that they need so that they can attain the highest level of health. So we need to change our policies. We need to look at where, we have residential segregation, and slowly but surely we're starting to address these issues like redlining. Yes, it's blatantly racist and people have called it out, but it's still happening covertly. We still know people who are dealing with issues as it relates to not getting mortgages, or maybe their house is not being sold because of their race. So these are things that we have to work hard on. So yes, absolutely. Wealth is a major issue as it relates to health. And one thing that's interesting is we have something called the health wealth gradient. And what that, I don't know if you ever heard of it, but what that references basically is that it says that through every descending step on the socioeconomic ladder, a person will experience poorer health outcomes. So it doesn't have to be from the top to the bottom. And we say, oh, this person has such great wealth, so his health is great. And this person has such poor wealth, his health is poor. Literally on every step that you descend on that socioeconomic ladder, your health gets worse and worse and worse. And so that shows you the importance of wealth, and it shows you the importance of resources such as education, and access to quality healthcare, living in that healthy environment, living in one that's supportive with resources. It really does affect one's health. Major issue.
Yeah, no, thank you for that. That's I'd not heard of the health wealth gradient, but that makes so much sense, as well as just thinking about those social determinants of health. And so while we all know there's a lot of structural, systematic things at play that affect certainly that wealth health gradient, but on a community level, on an individual community level, how can we think about changing those outcomes? Like, I know you mentioned that a lot of your research has been in the space around community engagement, right? In terms of research. So, like, what are some things that we can do as a community, or some things that communities are already doing to help address these disparities and ensure that the socioeconomic piece doesn't have to be a complete or a direct determiner of health outcomes for Black women and the Black community in general?
I think one that we need to understand, and this is sometimes disheartening for people who are not in public health, or even myself as a public health professional, we need to understand that it's not going to change overnight. That we have seen progress, though not in the way that we wish we were in terms of what we're seeing now, but we have seen progress from where we used to be. And that progress didn't happen overnight. So just making sure that and the reason why I point this out is because there's a lot of work that needs to be done. It's not easy work, but if you think that it's going to be changed overnight, you may become discouraged and you might want to give up. So to have that realistic mindset of understanding that we are making progress, though it doesn't look like it's happening and it doesn't look like night and day, we are making progress. So some of the things that I think we need to do, of course, and that's why it's difficult, is dismantle that structural system. And you see, even now in 2023, we're having issues about critical race theory. And, you would think that people are blowing bombs on people's homes. And we're just talking about critical race theory. We're talking about history. We're talking about how these systems really have affected many outcomes, especially health outcomes of Black people. And even having those discussions are hard, but we need to continue to have those discussions. We also need to make sure that we understand the issues that are happening in our communities, the issues that are happening with Black women from the mouths of Black women. And we need to make sure that we are engaging them in research, because we are underrepresented in research, especially clinical research. We need to really push to advocating and recruiting Black women into these studies so that we can have more specific knowledge of treatments and specific knowledge of programs, so that we can tailor these programs and tailor these treatments to meet the needs of Black women.
Well, that's all for today, folks. Enjoyed the show? Be sure to like and rate the podcast. You can find the Race, Wealth, and Health podcast on multiple platforms, including Amazon Music, Apple Podcasts, Google Podcasts, Spotify, and YouTube. Be sure to subscribe and turn on your notifications so you never miss an episode. I also want to hear from you, so don't forget to connect with me on social media. You can follow the podcast on Instagram and Facebook at Race, Wealth, Health. By joining the online community, you'll stay updated on the latest episodes, behind the scenes insights, and engaging discussions. Share your thoughts, comments, and questions there. I appreciate your support in sharing the podcast with your friends, family, and colleagues who may also find value in these conversations. Thank you again for joining me on this journey. Until next time, take care, stay informed, and keep up the good fight for equality.